Hello. In this section of anatomy and physiology videos, we will address the fundamental physiology of the respiratory system, as we have already addressed in parts 1 and part 2, the major and most important components of anatomy of the respiratory system. So to start with, I believe it's the best thing to explain what is the mechanism which actually drives the process of inhalation and exhalation. Why do we take the air into our lungs? Why do we exhale? If we have to do it, as we know, because we need oxygen and we need to release surplus of carbon dioxide from our body, we need to explain how is this possible that it happens. So if you don't mind, I'm going to share the screen. And as I do it, I'm going to first put a single diagram that will be interesting for us just to understand the plain and basic physics that is behind the process, which we have described as respiration. But we need to know also something else. The respiration itself is really like a multi-staged event. First, we need to do the ventilation. Ventilating our lungs practically means just one thing. We need to bring sufficient amount of fresh air into our lungs, from which we will extract oxygen, and we will also release the surplus of carbon dioxide back into lung spaces, alveoli, that'll help us eliminate carbon dioxide through the process of expiration or exhalation. Once we're okay with the principles of what are forces that drive the ventilation, then you and I can talk about external respiration, which is really like at the level of alveolus and pulmonary capillaries, where exchange of carbon dioxide and oxygen happens between alveolar spaces and the blood. And finally, we would need to allow blood to bring needed oxygen and to remove carbon dioxide from tissues. And that is going to be the process of internal respiration. So really, like, what do we need to know, or what do we need to understand is summed up perhaps in this diagram, which obviously shows us a container filled up with air, which surrounds us, and a movable piston, which will be moved in and out, obviously making changes in the volume of the container. If for a moment you're just thinking about this container actually is our lungs, it is going to help you understand. With the piston being in this neutral position, the volume of air filling up this glass cylinder is exactly 1 liter, and pressure of air filling up the cylinder is really 1 atmosphere or 760 millimeters of mercury. Should we change the position of a piston and push it halfway in, basically we will reduce the volume of this container to half a liter, from 1 liter to half a liter. However, it is also inadvertently going to change the pressure of trapped air or gas within a container, and the pressure will go up to 2 liters. We know that this is something that is practically very directly applicable to movement of air in and out of our lungs. And the process that we just explained is essentially essential of physics, so-called the Boyle's law, where pressure of gas and its volume are inversely proportional to each other. So when the pressure becomes reduced from 2 atmospheres to 1, it cannot be done in any other form than to allow gas to expand into significantly larger container. So this is just the very essential thing that we need to know for the start. And in order to go through physiology that drives air in and out of our lungs, you and I will have to go through some of the important things that we already studied. So this is the thoracic cage, which is composed of 12 thoracic vertebrae, 12 pairs of ribs, and the sternum, to which upper 7 pairs of ribs that we call true ribs attach directly. Remaining ribs, 8, 9, 10, 11, 12, are called false ribs because they either don't have attachment to sternum or they manage to attach to it only indirectly. As you can see here, cartilage of rib number 8 is not attaching rib 8 directly to sternum, it attaches it to the cartilage of rib number 7. So would cartilage of rib number 9 attached to the cartilage of rib 8, and finally cartilage of rib number 10 will attach to sternum indirectly by being attached to the cartilage of one rib above, that is rib number 9. Ribs 11 and 12, as you can see on this diagram, do have a very short, sometimes non-existent cartilage, and they remained only attached to same number, thoracic vertebrae 11 and 12. For that reason, we already know that we should call them floating ribs. Based on the multiple joints that are formed between ribs and vertebrae, or ribs and sternum, ribs are movable, and as a result of their movement, described as a bucket handle movement, basically ribs could be elevated during inspiration and ribs could be depressed during the exhalation. How is this possible? Well, it's possible because ribs are articulating to the rest of the skeleton through the joints, and these joints ensure that there is minimal but extremely important movement, which overall result not in the mobility of a rib, but rather about expandability of the entire thoracic cage. So when all 12 pairs of ribs become simultaneously elevated, basically it is going to result in increase of volume of the thoracic cage. And we know what's going to happen to air, which is still trapped within it. The pressure will go down. So expansion of the thorax increases the volume, but momentarily it starts decreasing the pressure of air that is still filling up at least partly alveoli. Exact the same application of a Boyle's law. We would need to take a look at another diagram which shows this same frontal plane section through the thorax and abdomen. Maybe this is not the best diagram, but at least it is going to help us understand a little bit better what's going on. You remember this proverbial piston that was inserted into a cylinder that started affecting pressure-volume ratio within it. Basically, you can think about thoracic cage being a container, and then the diaphragm itself is that infamous proverbial piston. We know that diaphragm is circumferentially attached to the lower part of the thoracic cage. Basically, parts of the diaphragm are attached even to lumbar vertebrae 1, 2, and 3. Then the diaphragm attaches itself to ribs 10, 11, and 12. And from rib 10, it is using multiple cartilages of ribs 10, 9, 8, 7 to reach the most anterior midline position to attach with some of its fibers to the lower sternum and to the xiphoid process. So when relaxed, the diaphragm is maximally elevated into the thorax. What does that mean to us? With diaphragmatic elevation, the volume of the thorax has been reduced, but the pressure of gas trapped within the lungs has gone up. And at one point, it is going to become higher than the pressure of atmospheric air, generating a gradient. Intrathoracic pressure being higher than pressure of air that surrounds us, atmospheric pressure, is sufficient enough to ensure that we can let the air out of our lungs and exhale. When the diaphragm is stimulated to contract, as it happens in the respiratory cycle, the contraction of the diaphragm actually moves the diaphragm downward into the direction of abdominal cavity. Applying Boyle's law, we immediately see this effect. By diaphragm being displaced inferiorly, it has directly increased the volume of the thoracic cage, and by increasing the volume, pressure of air within the thorax has gone down. It goes sufficiently down so that atmospheric air pressure becomes higher than intrathoracic pressure, creating again the same pressure gradient, which forces air to move from area of higher pressure atmospheric air into area or space of lower pressure intrathoracic cavity in lungs. Therefore, we see the mechanism that help us inhale and bring fresh air into lungs, and of course plenty of oxygen. Without our cells would not be able to survive pretty much hostile environment, which is with depleted oxygen and increased concentration of carbon dioxide. Innervation to the diaphragm is provided by perhaps a little bit of very awkward to explain two peripheral nerves. They're called phrenic nerves, P-H-E-R-N-I-C. These nerves come from a cervical spinal cord. They carry fibers of C3, C4, C5. They descend through the thoracic cage until they land on the upper surface of the diaphragm. They innervate about 70% of the diaphragmatic surface, remaining 30%, mostly of them being peripheral muscular fibers, are going to be innervated by intercostal nerves, practically coming from peripheral parts from the thoracic cage itself. And of course, that ensures practically perfect operations of the diaphragm. With inhalation, diaphragm goes down, pressure is decreasing, but volume of thoracic cage is increasing. The gradient is favorable to move air from high to low atmospheric air into lower intrathoracic pressured air compartment. When the diaphragm is relaxing, it means something else to us. It means that it goes up into the thoracic cage direction. It decreases the volume, causing increase of intrathoracic pressure, which, when it becomes greater than the pressure of atmospheric air, enables us to exhale. Certainly, for the diaphragm, we say it's the most important muscle of respiration. It is practically completely sealing the thoracic and abdominal cavities, separating them. Diaphragm itself will have some openings that are important for passage of aorta from thoracic cage into abdominal, from thoracic cavity into abdominal cavity. Opening for aorta is leveled at T12, then large opening for the esophagus leveled with T10 vertebra that is accompanied by opening at the level of T8 vertebra, opening for the inferior vena cava that will collect venous blood from practically lower limbs, from inside of pelvic and abdominal cavity, and bring deoxygenated blood back to the heart. Additional muscles that are required are called accessory muscles of respiration. Some of them would be able to assist in elevation of ribs. Therefore, we see that ribs, when elevated, increase the volume of the thorax. That'll lead subsequently to inspiration. For that reason, we call them accessory muscles of inspiration. Those are external intercostal muscles, which elevate ribs, such as also anterior, middle, and posterior scalene muscles that would not elevate all ribs, but at least would be elevating ribs 1 and 2. Muscles that do the opposite, which speed up depression of ribs, are called also accessory muscles of respiration, but better to call them accessory muscles of exhalation or expiration. Those muscles are internal and innermost intercostal muscles, abdominal muscles as well, because when they contract, they would greatly increase intra-abdominal pressure. That pushes quite abruptly the diaphragm upward, and abdominal muscles certainly can do quite a lot of work to speed up the exhalation process. So when we know thoracic cage features, now we know more about innervation of muscles that are essential for the respiration. And as we know what muscles assist in providing inspiratory versus expiratory effort, you and I would need to take a look and try to understand how this system works. What really leads to control of ventilation? Because as we know, neither you or I are thinking about now I need to inhale, now I need to exhale. It's happening as process, which is very automatic, and it doesn't stop even when we are in our bed, when we're deeply asleep. So in order to understand this, you and I will have to quickly go back through the diagrams of this chapter that is talking about respiratory system. And as they are at the very end, you don't mind if I just go all the way to the end and point out to two different parts of the brain where control of the respiratory system is arranged. This is the spinal cord, which upon its entry into cranial cavity becomes the brain stem, consisting of the lowest part, medulla oblongata, middle part being called the pons, and uppermost part of the brain stem, which is named the midbrain or mesencephalon. Within medulla oblongata, we're to find medullary rhythmicity area, which obviously have two controlling centers, inspiratory and expiratory area. So this is how it works. Every 5 seconds, because we can say that's our average pattern of respiration, because we breathe in between 12 to 16 times per minute. And if that's happening at the rest, we're using the word that we are experiencing eupnea, as opposed to tachypnea or bradypnea that would denote faster than normal or slower than normal respiration. Tachypnea is slower, bradypnea is lower than normal. So how does it work? We'll find out that we have some chemoreceptors within the body that are carefully monitoring controlled condition, which is concentration of oxygen, concentration of carbon dioxide, as well as concentration of hydrogen ions within our body fluids. These chemoreceptors are going to be essential to detect any kind of changes to prevent any additional and unneeded buildup of hydrogen ions or carbon dioxide. But we are also not too keen on having excess of oxygen, because we should remember always the body is just about the equilibrium, about the homeostasis. Everything that we need is there. It has to be done in moderation, and none of the abrupt changes could be easily tolerated by body. So this is how it works. During the quiet respiratory cycles, as we're practicing right now, me as I'm talking to you, you as you're probably listening to this, we're setting the pace of between 12 to 16 respiratory cycles per minute. So when we're completing the last cycle, when we exhaled, it means that we already have experienced enough buildup of carbon dioxide and hydrogen ions that will trigger some kind of event detected by chemoreceptors that'll stimulate the inspiratory area, which in turns generates signals to muscles of inspiration, forcing us to breathe in fresh air. Once it happens, we do not delay. And contrary to what most people would believe or try to make a conclusion, the expiratory area during these quiet respiratory cycles is really inactive. At the end of inspiration, as it happens, basically we just let the recoil of our lungs that have lots of elastic fibers to start shrinking the lungs, as well as natural recoil of the entire thoracic cage starts shrinking the thoracic cage. You remember Boyle's law. If the volume goes down, pressure goes up. So as the recoil of lungs increases the pressure, if the recoil of thoracic cage increases the pressure, at one point we just start spontaneously exhaling air out of our lungs. In the meantime, pressure of carbon dioxide and concentration of hydrogen ions has slightly risen, and that will prompt another quiet respiratory cycle to just keep happening on and on, as we said, at the pace which is 12 to 16 respiratory cycles per minute. However, we know that our respiratory system, when it operates at the quiet cycles, is good to support the body at rest. But we're not always at rest. Sometimes we increase the level of physical activities, and that will result immediately in increased need for more oxygen to be quickly delivered to the tissues. And that means that we will go from 16 cycles to 20, 25, or maybe even 30 or greater number than 30 of respiratory cycles per minute. How is that possible? Well, same chemoreceptors are always be active, but in this case, they're going to be also stimulating two centers that are located within the pons. As you can see, within the pons, we have controlling center, which is called pneumotaxic area, and controlling center, which is called apneustic area. So let's try to explain what these two centers would do before we move on to the next diagram to see more directly about their role. Pneumos in Greek means air, taxein means to move. So pneumotaxic area actually is the one which controls movement of air into our lungs. To make sure that you immediately understand how it works, I'm going to ask you to do this together with me. Let's try to take a deep breath together. On the count of three, inhale as much air as you can. 3, 2, 1, go. You realize that at one point, your attempt to inhale comes and reaches abrupt stop. That is controlled by pneumotaxic area. Why? Because it prevents your lungs being overinflated. Just use the analogy of a rubber balloon. Happy birthday. You're just about to start inflating 15 or more balloons, and you know what's going to happen to each and every one of them if you overinflate them. The elasticity of a rubber is not going to be able to withstand the pressure of trapped air within a balloon, and the balloon will pop. That would happen to our lungs if we overinflate them. So that is what pneumotaxic area is doing. And apneustic area is the one, word apnea means lack of breathing. So apneustic area is going to be the one which controls and stimulates inspiratory area in order to increase its pace and to make sure that we are having progressively greater and greater number of respiratory cycles per minute in order to properly serve the metabolical needs of our body. On the next slide, these two, medullary rhythmicity area and pneumotaxic and apneustic area, are going to be a little bit easier to understand. So during the normal quiet respiration, basically we know that this is inspiratory area within medulla oblongata. When active, and activation lasts for about 2 seconds, diaphragm, including other muscles that are accessory muscles to inspiration, are contracting. Air moves in. When a contraction comes to its end, basically recoil of lungs and recoil of thoracic cage, which lasts a little bit longer, about 3 seconds, diaphragm, external intercostals relaxed, followed by elastic recoil of chest wall and the lungs, leads to normal, quiet exhalation. So one can ask a question. I don't see here how pneumotaxic and apneustic area are working. Okay, well, both of them work on inspiratory area, telling it go, inhale, and then stop with inspiration. And both these centers will also be stimulatory to expiratory area, so that we do not rely any longer to just a very slow and passive recoil of lungs, relaxation of muscles. Therefore, we would need to actively involve muscles that are accessory muscles of expiration to speed up the process and to reduce it from 3 seconds to perhaps something that lasts 2 seconds or less. So with the inspiratory area being activated or stimulated, again, diaphragm, sternocleidoid, mastoid, scalene muscles, external intercostals, all of them contract together, resulting in a more forceful inhalation, which shortens the length of a cycle. Apneustic area is activated, as well as pneumotaxic area. Keep in mind, pneumotaxic area brings the end to forceful inhalation in order to prevent overinflating of the lungs. It is time for pneumotaxic apneustic area to gradually shift their controlling powers and to start stimulating expiratory area within the medulla. That will send signals to a number of different accessory muscles of exhalation, like internal and innermost intercostals, abdominal muscles. They start contracting, they more rapidly shrink the thoracic cage, which results in a forceful exhalation of air. And as you can see, it really all boils down to Boyle's law. Pressure volume within enclosed container is inversely proportional. You increase the volume, you decrease the pressure. If you increase the pressure, it can be only done by decreasing the volume. And that is how it works all the time. Earlier, I've mentioned something like chemoreceptors. So let's try to understand this kind of controlling mechanism, as we see here a composite diagram illustrating brain with some of the cranial nerves, like glossopharyngeal nerve, cranial nerve number 9, that innervates carotid sinus and carotid body, and then vagus nerve, cranial nerve number 10, which is important to innervate chemoreceptors within the wall of aorta. Basically, there are additional chemoreceptors within the brain that are detecting any changes in increase of hydrogen ions or increase in partial pressure of carbon dioxide. They would stimulate medullary respiratory area for sure, but it is not about just what the brain has been served, because brain might be in a somewhat protected position, being put on a pedestal, saying, I need that much oxygen in order to proper function. But the rest of the body also cannot be completely excluded from this. So that's why in larger blood vessels, such as aorta, and at the bifurcation of common carotid artery into external and internal, their walls contain also chemoreceptors measuring the same two equilibrical mechanisms. And if detected, the change is going to be immediately resulting with more input provided to brain, to medulla oblongata, to medullary rhythmicity area, as well as further up to pons, to apneustic and pneumotaxic area that will control increased frequency of respiratory cycles. So here is one of the diagrams which I really like sharing with students. Some of the stimuli is disrupting the measured homeostatic balance of the body. When that happens, what may change is that we're measuring increase in arterial blood partial pressure of carbon dioxide or decreasing pH of the blood or decreasing partial pressure of oxygen. You realize what happens, for example, just to clarify, the decreased pH. So the blood or other body fluids are skewed more into acidic range. They're coming closer to a value of 7, and we know that optimal pH value for a body is between 7.35 to 7.45. So if blood becomes 7.3 or 7.2, that is, of course, due to increase of hydrogen ions. What's happening? We have metabolism, which produces carbon dioxide. Carbon dioxide easily and quickly gets engaged in a chemical reaction with water. H2O plus CO2 result in the formation of H2CO3, carbonic acid. And this acid, although it's a weak acid, starts dissociating, yielding more hydrogen ions and bicarbonate ion with a single negative charge. So that is why the mechanism is controlling not only partial pressure of gases, but also slight change in acidity of body fluids such as blood. Central chemoreceptors within medulla oblongata or peripheral chemoreceptors located within arch of the aorta or carotid bodies are to detect such a change, and as a result will provide quick input to a controlling center, which in this case is inspiratory area located within medulla oblongata. Change has been detected and a controlling center has been informed about the change. Immediately, output will be generated by medullary rhythmicity area. That'll keep sending impulses into muscles of both inhalation and exhalation to start contracting more frequently, more forcefully, and we are to end up in a part that we can say a person hyperventilates. Hyperventilation, which is for this moment very good, will result in arterial blood pressure of carbon dioxide being decreased. And of course, pH value of the blood will go up towards normal range between 7.35, 7.45. It will increase concentration of oxygen molecules being bound to hemoglobin, therefore partial pressure of oxygen will also go up, which will bring the controlled condition back to normal. So once again, we're using the example of a negative feedback loop. We're returning to homeostasis by bringing back normal values of partial pressure of oxygen, carbon dioxide, normal value of pH, and at that point, basically, it is going to interrupt this cycle. If the cycle is not interrupted, then if we allow hyperventilation to continue, we can think about an additional scenario, such as by hyperventilating, we're removing excess carbon dioxide, but we're removing more than what the body wants us to remove. Partial pressure of carbon dioxide keeps going further and further down. Now, what's going to happen? We don't have sufficient amount of CO2 to produce carbonic acid that yields hydrogen ions. Instead, we start seeing increase in concentration of bicarbonate ion and blood shifts into alkalinity. So what would happen if a person is voluntarily trying to hyperventilate? This could be quite a damaging effect. And if a person is determined to keep doing it, at one point they would faint because their hyperventilation essentially created quite the opposite, not normal, not natural conditions, resulting in alkalinity of body fluids and clearly a very, very much deficit of carbon dioxide. So the person will faint. As they would faint, what's going to happen to their respiration? Not only did they would stop hyperventilating, they would not be breathing for next 15, 20, 30 seconds, or maybe even more, until sufficient volume and sufficient partial pressure of carbon dioxide in their blood goes up, establishes normal pH of blood and other body fluids. And of course, at that point, concentration of carbon dioxide, which reached the normal level, will simply start triggering medullary rhythmicity area in person who fainted, who was first without respiratory cycles, will resume the normal respiration. So at this point, I believe that you and I have gone with number of different details through basic respiratory system physiology, but I dare to say its principles of ventilation. It all spins around Boyle's law, pressure, volume being inversely proportional to each other. And after we have successfully ventilated lungs, basically there is just a little extra thing for us to do to include external and internal respiration to find out how the blood releases CO2 into alveoli in order to collect more oxygen from alveoli back into bloodstream, and how the same blood, which is now with higher oxygen content, can deliver it to tissue where we see utilization of oxygen at the cellular or tissue level, and that is what becomes for us the internal respiration. For now, I think that this might be good enough, long enough to complete this and to title this video presentation, Essentials of Respiratory System Physiology, Ventilation, and to wait for part 2 that will explain with more details internal and external respiration. Thank you for watching this video. Please either like the video if you really like it, or subscribe to my YouTube channel and perhaps find a few other things that might be your interest or falls into a field of your studies. Thanks again. See you soon.